Peter and Paul grew up with different views to show. One from a bankrupt farm in town, the other from a hardened ghetto. But both of them heard the call just as soon as they turned 18. Said goodbye to their families, heading off to become Marines.
Hello, my name is Asim Shah. I am a psychiatrist and I work for Baylor College of Medicine. I'm professor and executive vice chair in Baylor College of Medicine Department of Psychiatry. I'm also the chief of psychiatry for Bentob and Harris Health System. Today we're talking about mental health. We're talking about mental health in young folks, whether they are teenagers or early teenagers. And we're also going to talk about the mental health scenario with specific relationship to different religions, different ethnicities, and different cultures. Mental health is something which is very near and dear to me. Why? Because I feel that this is something which is ignored. There's a lot of stigma with mental health. Even the word mental health has stigma in it because the word mental creates stigma. So I try to often call it by a name called brain health or psychiatric health as opposed to mental health, just to reduce the stigma. Why mental health is important in this state? Texas is perhaps one of the most underserved or uninsured population state when it comes to physical illnesses and especially mental illnesses. So that's one. We also want mental illness and we also want people who suffer from mental illness to not have any hindrance in terms of care. So for example, if you don't have any money, you still need to be able to see somebody who can give you some help, who you can see and approach help. Now, help is important, of course, but help is important at the right time. So access of care is important, but early, easy access of care is the most important thing because you don't want to see somebody once you have full-blown symptoms and it is a little too late. So we don't want that. Why it's important in kids? Why we talk about it in young people? First of all, over half of the psychiatric illnesses start before the age 18, actually before the age 14. So that's important. Substance use, if you think about substance use, which about 60–70% people who have mental health do have substance use issues. Substance use is very common and it starts, at least 25% of substance use starts before the age 14 also. So we need to talk about mental health with the young age because these things start at a young age. Secondly, if you look at the full-blown episodes of psychosis, of mania, they usually happen in teenager group, 18, 20 or early 20s. So that young population, that high school population or that early college population is unfortunately the target age when these full-blown psychotic symptoms or manic symptoms happen. And if we don't know what we are looking for, we are going to miss it. Thirdly, if we talk about suicide, which is the most serious complication of mental health, suicide is the second leading cause of death in ages between 14 and 24. And some people say even in ages between 14 and 34. So that also is a big problem. And just a little bit about suicide. Every year in this country, about 45, 46, 47,000 people die of suicide. That's a big number. Half of them hurt themselves because of a firearm, which is another debate. But again, access to firearm, if somebody has psychiatric symptoms, can be a problem because with firearm usage, there is very little chance of a person surviving. We also have each year about 250,000 or 250,000 people who survive suicide. The number one predictor of suicide or a future suicide is previous suicide. While we need to worry about the 46,000, 47,000 people who die of suicide every year, we also need to worry about people who survive suicide, the 250,000 who survive suicide each year. Why? Because that is the number one predictor of a future suicide. And if we can save some of those lives, that is always a very good thing and that is very beneficial. So that's something important also. Substance use. Substance use is extremely common. Some people don't think that alcohol is a drug of abuse. Some people don't think marijuana is a drug of abuse. Some people feel that marijuana is legal. It's not legal in Texas, so not for us at least. And the other problem with these substances is that whether it is marijuana or alcohol, they can be gatekeeper for other hard drugs. So let's start with substance use. Alcohol. Alcohol in mild quantity may be okay, but when people drink, sometimes they don't remember that they're drinking more and more and more. And what we say is that anyone who is drinking more than 8 ounces of beer or so every day, that could be something of a concern. And if you're drinking more than 14, 8 to 12 ounces of beer in a week, and if you're a female, more than 7 in a week, that could be a very dangerous sign. Why less for women than men, or female than men? Because the threshold of tolerance is less in women than in men by nature. So we have to be careful about that. Marijuana is another thing. What marijuana does to young people, it causes amotivational syndrome. People who use marijuana decrease their motivation, and people say that it relaxes me. And yes, it does relax you, but it relaxes you a little bit too much that you don't care about things. Certain amount of stress is always good for life, because stress is a motivator. Stress motivates you to do things. But if you don't have any stress, any urge to do things, you become kind of immotivational. So marijuana does that. Of course, marijuana and alcohol are very common in Texas, but after marijuana and alcohol, if you're talking about Houston specifically, cocaine is our third commonest drug of abuse in Houston, whether it is crack or cocaine. If you are in a countryside, whether it is Lubbock or small areas, meth becomes more common than cocaine because it may be cooked in the backyard. And then after these 3 or 4 drugs, we have PCP, which is relatively common, Kush, which is relatively common in our state, in our city. Then come prescription medications. People tend to use a lot of prescription medicines, and some tend to abuse them. Xanax is the prime example. People buy it from the street and abuse that. People abuse pain medicines, Vicodin or so, muscle relaxants. And young people also tend to abuse stimulants, whether it is Adderall or any other stimulant. And they feel better, and they feel that they're able to focus and concentrate with that, and they want to take more and more, and that could be a problem. So we need to be careful about that. Now, back to psychiatric illnesses. Depression is, of course, the most common psychiatric illness. Over 20 million in the country suffer from depression, and there are warning signs and symptoms of depression. So the commonest warning sign and symptoms of depression would be losing interest in things. So if you are a person who enjoys playing sports, games, or watching TV or hanging out with your friends, if you're not doing any of that, that means that you have lost interest in activities you used to enjoy. That's the number one warning sign and symptom of depression. So lack of interest or not enjoying things is one. Then it is combined with the depressed mood, combined with the lack of energy, and those things all are symptoms of depression. In addition, some people sleep less, sleep more with depression, eat less, eat more with depression. Those are non-specific symptoms, but happen too. So in short, if you're thinking about depression and how to diagnose depression, think about a person who has lost interest in things, who is depressed, and who has no energy. As opposed to depression, there is another phenomenon called mania. In mania, people have tons of energy. They have a lot of energy. They are unable to sleep, and they are all over the place. So if you think about mania, it's too much energy and inability to sleep, and then you act erratically, you are irritable, maybe talking too much, too fast. That would be mania. If you think about psychosis, psychosis is one of those diseases in which people not only hear voices and see things and feel people talk about them, they have impaired reality testing. How do you define that? Impaired reality testing is a phenomenon in which a person is unable to separate reality from what is unreal. And the classic example of that is that anybody who wants to know what psychosis is, I recommend them to watch a movie called by the name Beautiful Mind, in which it separates it very easily what reality is and what is not reality. Because a lot of people do hear voices even in depression, but they understand that this is a voice they're hearing and there is nobody there. That's not impaired reality testing. In psychosis, people cannot separate that, and that becomes a problem. Why do I mention that? Again, 18, 20, 21, those are the age groups when manic symptoms start or psychotic symptoms start, and a lot of time depression starts. So we need to be very careful and try to get people help when they have these symptoms. One more thing to remember is that people try to hurt themselves, and self-harm is another issue. So why do people harm themselves? One thing which comes to mind is a lot of times, especially in women, can be in men also, but a lot of time in women or girls, they are they may have a history of perhaps PTSD or some kind of abuse, whether it is physical, sexual, emotional, or all three together. And they feel abandoned, they feel neglected. And when they feel abandoned, when they feel neglected, when they feel that nobody cares for them, sometimes the only way for them to feel themselves is to self-harm. And in particular, I'm talking about cutting or slashing their wrist when people repeatedly cut themselves or have cuts on their forearms or their legs and so forth. That is the most common cause of self-harm young people tend to do. It happens a lot in borderline personality or cluster B traits, which happens because of a prior history of some sort of abuse. Therapy is the best treatment for that. Medication may not be the best treatment for that. Therapy may be the best treatment for that. And then there are other self-harm ways people do. People can hurt themselves with other means of suicide, but the most common self-harm means is what I mentioned, which is slashing their wrist or cutting their wrist and those kind of things. A lot of these things happen to people when things are not going their way, when they feel abandoned, when they feel nobody is listening to them. So in some way, if things are going their way, their mood may be better, but if they're not, the mood can suffer and self-harm can be a result. Now, if a young person is affected by any of these symptoms, what do you need to do? Do you need to give them medications? Do you need to provide therapy? Both are fine. Therapy is something which is very good, especially if done in the right way. So therapy with the experienced psychologist can be one of the best options. But therapy demands commitment. You have to see the therapist maybe once a week, maybe even twice a week for 8, 10, 12 weeks, or maybe even longer. So there's a lot of commitment needed in therapy. If you're having therapy once a month, that's not going to change the course of your illness. If you cannot commit to that 12 or 16 week, perhaps therapy may not be for you. Certain diseases improve better with therapy, in which borderline personality is one of them, that therapy is perhaps the keystone for treatment. And then if you think about medications, medications are in some ways a rather quicker way in some people because they don't have to commit to seeing somebody on a weekly basis. But therapy in conjunction with medicines would be the key. Medicine alone should not be the best course of action. What kind of medicines we can use? We can use antidepressants if somebody is depressed. They also help in anxiety. 2/3 of the people with depression do have anxiety, and 2/3 of the people with anxiety do have depression. So SSRIs, SNRIs are a group of medications which can help both scenarios. Then if a person has psychosis, we can use antipsychotics. They work rather very quickly, and psychosis can be treated rather very quickly, but you may have to continue the medication. Then if somebody is manic, we have mood stabilizers which can be used. So today, in today's day and age, we have a lot of good medicines which can be used, and these medicines help a lot of people, and a lot of people get help by continuing to take the medicine. One more thing which is rather common in young people is eating disorder, anorexia, bulimia, and people don't think about it. So some teenagers, some young adults do have an image of themselves that they start feeling that they are a little more obese than what they are. So if their weight is 90 pounds, they still feel that I'm more fatter than somebody else. So their body image is distorted. And because of that, they start either dieting, eating less, or if they binge eat, then they try not to eat to cover up, or sometimes they throw up also, called bulimia, meaning put their hand in their mouth and throw up, forced vomiting, called bulimia. These disorders are also very common and can affect men and women both, more usually women than men, but can affect both. And they're treatable, but therapy is the cornerstone of treatment for these disorders also. So in short, adults, young adults, teenagers can suffer from depression, can suffer from mania, can suffer from psychosis, can suffer from anorexia, can suffer from PTSD, post-traumatic stress disorder. All these can happen. The point is that our goal is to identify these disorders at an early stage, not only identify, get them access to care, get them treatment, and continue the treatment. We cannot avoid treating these disorders because if we do that, that causes impairment in their functioning, and that can cause complication, and one of the complications can be suicide. So we need to be very careful. Similar thing happens for substance use. While substance use is common, help is available. We can get them help, access to care. And not only that, if family is supportive, they are able to get rid of their substance use. In terms of suicide, there is a 1-800 hotline for a suicide, which is 1-800-273-TALK. Anybody can call anytime, and that is available, and they can try to connect you and give you resources and try to help you over the phone and decompress your emotions. All that is available through 1-800-273-TALK. Another topic which is rather very common in young people of school-going ages and teenagers and young adults, is bullying. Bullying is something which is more and more common these days, but people still don't accept it. There are different kinds of bullying. First is bullying which happens in school or college, meaning in-person bullying. Then there is cyberbullying, which is becoming more and more common, especially during the era of COVID, because people are at home. So a lot of these things are happening through social media called cyberbullying. So first is, who is a bully? Bullies are usually people who are within themselves insecure. They are weak people, and they project their weakness by attacking somebody else who they feel is vulnerable and weak. So for a bully, target would be anyone who they feel is weak and they feel is vulnerable. So first rule of bullying is that if you feel that somebody is bullying you, you can stand up, you can stop them and not show any weakness, even if you have a weakness. Second thing is, people talk about that maybe parents need to confront the bully and so forth. Usually studies have shown that if you find out that somebody is bullying your child, it's best for parents not to confront the bully. Parents need to go to the school authorities. Parents need to talk to a school counselor or school principal, let them confront, be out of it. Because if they confront the person, the bullying can increase to that child. So best is to approach the school authorities. Lastly, we all need to open communications with our kids, because when bullying happens, a lot of time kids don't talk to parents, and that should not be the case. So the best scenario would be that if you know your child is showing some signs which are different than normal, child is quiet, child is withdrawn, child is not doing things, child is not wanting to go to school, whereas the child wanted to go to school before, not going to see their friends, whether they used to like that. So that's a change in their behavior. If parents see change in the behavior, this is the time parents need to explore that. And one of the ways to explore is to try to talk to them, open communication and say, please, if anybody ever bullies you, ever talks to you bad, whether it is cyberbullying, social bullying, or school bullying, or college bullying, discuss with them. You can teach your child to be strong enough to stand up to a bully. You can teach your child to ignore that bullying. And one easy way to stop bullying is to ignore it, because when they feel that you are not giving into it, they tend to find another target. Unfortunately, they will find another target, but it may not be you. Sometimes it's easier said than not that ignore it, because it could be so harsh that you cannot ignore. But please talk to somebody, either if it's school authorities, college authorities, your parents, and parents need to talk to their kids and educate them about bullying, that if that happens, help is available. Because if we don't pay attention to bullying, it can cause a lot of problems. And in some cases, it can be even very dangerous with complications. So please look into those and try to get help for those people who are bullied.
Hello, my name is Jane Barnes. I'm the CEO of the Memorial Hermann Prevention and Recovery Center, better known as PARC, in Houston, Texas. We are located at 4043 Gessner. We offer all levels of care for substance abuse, for adolescents and adults. We have a detox program here. We have a residential program here. We have day program and intensive outpatient services. We also have 6 intensive outpatient services located throughout Greater Houston. Our primary focus is to help addicts recover from addiction and find resources to continue in a road to recovery.
Hi, my name is Stacie Allphin, and I'm the Director of Program Services for Memorial Hermann Prevention and Recovery Center here in Houston, Texas. We offer a variety of programs from adolescent all the way to adult, inpatient, outpatient, and even some specialty programs. But I'm going to let Traci talk about those.
Absolutely. My name is Traci Gauen. I'm a licensed chemical dependency counselor, as well as a licensed professional counselor. We offer all levels of care, starting from detox to residential to day treatment and intensive outpatient. We serve the adolescent population starting at age 13 to age 17, and we also address the adult population as well. We have different tracks at our facility. We have a pain recovery program, and this is tailored to individuals that struggle with chronic pain that may be addicted to pain meds. So we help patients manage their pain without using intoxicating substances. We offer them different coping skills they can use in lieu of using those drugs. We also offer a professionals and executive track as well. We also serve the young adult program, and that's typically ages 18 to 24. So as you can see, we offer a wide variety of tracks, which vary depending on the need of each patient. We offer a individualized treatment plan as well. So we meet the patient where they're at, we ask them what their goals are, and we make the treatment plan tailored to their needs.
In addition, we use a variety of modalities, including action methods, CBT, DBT, we use hypnosis, EMDR, a variety of avenues to help that person get whatever it is that they need from treatment.
Exactly. And for our pain recovery program patients, the patients that struggle with chronic pain, we offer yoga, acupuncture, biofeedback, physical therapy. We teach patients, that motion is lotion. A lot of our patients are really fearful of their pain going up once they stop taking their meds. So this is a really good place to learn how to manage your pain without using drugs or alcohol to cope.
So PARC is a 12-step philosophy-based program, meaning that we believe in complete abstinence as opposed to a maintenance or a harm reduction approach for people that suffer with addiction to mood-altering substances.
So for the psychological part, we see a lot of our patients self-medicate any depression, any anxiety with drugs and alcohol as well. And to address the environmental aspect of this disease, we really encourage patients to build a sober support network. For our adolescent unit, we recommend that our patients go to a recovery high school. It makes it a whole lot easier if you're around people that are doing the same thing. You're more likely to engage in that behavior as well. We also recommend that our patients get involved in alternative peer groups. That provides a really good way for support for the patient as well as the family. So the parents get support from parent support meetings and the kids get support as well. The bottom line, I believe, is that the adolescent population really thrives on structure. So the more structure that you have, there's no what are we going to be doing today? And I really think that the adolescents really thrive on having a structured daily activity schedule. So it's really important for kids to come to treatment that they really follow our daily schedule. And really the things that we teach the patients here, we want them to continue doing those day-to-day activities outside.
Our adult program is awesome. So we have several different types of programs within our adult program. So we have the professional and executives program, which is really geared for those professionals that may have certain licenses on the line. Maybe that you're part of, maybe you're a lawyer, you could be a physician, the nurses. We've had a lot of teachers, a lot of different executives in all kinds of companies. Anybody that you can think of, we've probably had someone from that company. So we're really good at helping those people get back on track, working with whoever maybe their peer assistant board, so to speak, for their licensing, to help them either remain in their profession, hopefully, if that's going to be a good environment for them, or sometimes they need to make a decision to make a change. And so we are just there to help them facilitate and work through whatever those processes are. The majority of people obviously want to keep the career that they've spent all this time, developing and building. So that is our main goal, is to help them get back to a place where they can function in a really safe and productive manner and to have a happier lifestyle. People are so amazed when they leave that program at how many things are tied to the relationships throughout their lives. They really they lose sight of that in the success and in the use of whatever that substance is for them. So that's our P&E program. And then the young adult program is awesome because we have really spectacular counselors for that particular age group. They do some very different things than the other adults. It's much more peer driven, and because peers listen to peers, you know, that's how it works. So they do a lot of role play. Sometimes they'll come up with skits and perform for the entire facility. They do music. They do just a wide variety of different activities, including working out with our own fitness guy who was on the Ninja Warrior show. So that was really cool. So they get competitive, and we try to make it fun because, you know, life is supposed to be a little bit fun too. So if you're not going to be having fun in sobriety, what would be the point of continuing? So there's a lot of that. And then with all of our other programs, you know, people are getting individual sessions, they're getting family sessions. We have a family program that is as good as any other, if not better. I would like to say it's way better than any other program out there, because we really want the families to be involved, because this is not just a stressful time for a person who has addiction issues or anxiety or depression or whatever other mental health may go with that. The family takes a beating at times. They feel helpless, they feel hopeless at times, and our job is really to help empower them in taking their life back so that they can support their loved one in a different way than what they've been doing. So there's many facets to mental health and addiction, and really they're so woven within each other. And it really does takes a village. It really does. You need everyone to be as invested as the family is invested.
Some questions that you may want to consider if you're contemplating whether or not you have a substance use disorder is maybe if you have any withdrawal symptoms when you stop taking drugs or alcohol. Maybe it takes you longer to get high or longer to get intoxicated. That could be a symptom of that you're developing some tolerance as well. If it's interfering with your daily life, if it's causing disruption at school, at work, with your relationships with other people, maybe if you tried to stop on your own and have been unable to. So say, okay, I'm going to stop drinking on Monday, and Monday comes around, okay, maybe I'll stop tomorrow. Also, if you have intense urges or cravings to use, that may be a symptom that you have a substance use disorder as well. We go by the DSM-5 criteria to diagnose if someone has a substance use disorder, and that's one of the, you have to have a substance use disorder in order to be in our program, obviously.
So we do a symptom-driven detox here. So instead of just having a set form that says, okay, this person is having issues with alcohol withdrawal, so we're going to give them X amount of Valium, for instance, every person is met with individually, and based on how many symptoms that they actually are displaying and that you know, are observed by the nursing staff, that is how they determine how much medication, if any, is needed during that detox. Obviously, our want is to have people be comfortable, because it's scary enough when you first come into treatment, but then to look at possibly having to detox, it can be a little nerve-rattling. So we want you to be comfortable, but we also don't want to over-medicate people. So because of this, I think we have a much safer, a much more effective, and a faster result with our actual detox. The other thing that is really important is that we have one of the few detox programs for adolescents in the entire country. So we do the same thing with them. It is, again, symptom driven. It's very safe, and it seems to be very effective, and it's been going on for years and years at the PARC. So it's really 100%. Also, the patients that are in detox are able to go to any kind of programming that they're feeling up to. So we do have special programming just for detox patients that help them kind of look at maybe why they ended up coming in here, maybe what we might be able to help them with while they're here. Because really in detox, we want them to just kind of go ahead and go through that process of getting things out of their system, but we want them to have some little tidbits of knowledge just in case they're confused about why maybe they came in.
So we have our day treatment, which lasts about 2 to 4 weeks, and it's all based on the need of the patient. Every week we update their treatment plan so we see where they're at, and our day treatment meets here at our facility from 8 till 4, Monday through Friday. We also encourage our patients to continue their support with our aftercare. So our aftercare is awesome as well. It's another support group. Just like a 12-step meeting is peer run, the aftercare is peer run too. And their aftercare facilitator is really a patient that's been through the program and has completed their year of aftercare as well. So we have a very robust aftercare program. Our intensive outpatient program is pretty neat as well, because we can work, if someone works a 9 to 5 job, we have our evening IOP, which is typically 3 hours a day, 4 days a week. And again, the length of the IOP depends on the need of the patient. Typically, we see about 20 to 25 sessions of our IOP program, and the adolescent program as well, which is really nice because we partner with the Recovery High School as well. So they will come here for treatment for their outpatient program. They will also attend school with the other patients, which is kind of nice because a lot of them, they build their recovery support with their with the other kids that they're in treatment with. So it's really cool to see them all grow, and they really start to hold each other accountable the further along that they're going on in their recovery. So it just warms my heart to see that. But it's really cool because they will go to school here as well as do their intensive treatment with their counselor. So we do process groups as well as CD education. So we're really trying to help them change how they think, really trying to help them, how can I manage my depression? How can I manage my anxiety without using? Because as we know, a lot of these kids will use to self-medicate, they'll use to change how they feel. And when we take away that biggest coping skill, sometimes their mental health does become a primary issue.
So my name is Dr. Kelly Watts. I am a psychologist and resilience coach, and I work often with clients who have experienced trauma. One of the forms of therapy that I use is one of the most popular and research-proven methodologies, which is called EMDR. And Frances Shapiro, who created EMDR, said if she knew how effective and popular it would become, she probably would have given it a cooler name, because it stands for eye movement desensitization and reprocessing. And what EMDR does, that sounds really complicated, but in fact it's quite simple. The last 10 years there's been an explosion of research around what happens physiologically and specifically in the neurology of your brain when we go through trauma. And in EMDR, or all trauma work really, we think of trauma in two ways. Historically and traditionally, when people think of trauma, they think of some major event, an assault, a car wreck. Veteran experiences obviously often get classified in a traumatic experience list. What we've learned is that those we call big T traumas, and we often have what we call little t traumas. And those are life experiences that we might minimize or not think are as bad because they weren't life-threatening, but they can be similarly damaging, and they have similar processes in our brain in terms of where that information is stored. So over the last decade, and with the advancement of brain mapping and research, we can see what happens in someone's brain when they think about certain things, where certain memories, where your brain lights up when we talk about certain things. And essentially what we've learned is that traumatic memories are stored differently than other memories. And difficult experiences are stored on your right side of your hemisphere of your brain, and the language center of your brain is on the left side. And so that's why talk therapy can be limited. It's helpful with trauma, but it's limited, and there's only a certain amount of healing you might experience. So many clients who have done therapy for many years and found some relief, but not full kind of healing and integration from those experiences, come searching for a different modality. So EMDR clinicians use EMDR, which is a system of activating those memories and stimulating the brain in what we call bilateral stimulation. Again, fancy term to simply mean two sides we stimulate the right and the left side of the brain so that they talk to each other. So we get those memory networks working and moving in the brain. So EMDR therapists and all trauma therapists usually work with a variety of modalities. And so I might use cognitive behavior therapy and EMDR with a client as we recognize some of the beliefs that have been stored in a dysfunctional way in their brain. So EMDR accomplishes a number of things, and one of the reasons I really appreciate it as a modality is because it doesn't require a client to walk through the details and nuances of a difficult experience. It allows them to activate that part of their brain and move that from a dysfunctional dysfunctional memory to a functional process. So this might occur, for example, if a client had a panic attack while driving across a high bridge. They may then feel like they get panicky or they're scared to even try to drive across a high bridge. And so the body sensations that occur for them, even in anticipation of a similar experience, can be really debilitating. And so we're finding that EMDR is effective for not only the big T traumas, but also for phobias, anxieties, self-esteem and confidence issues, as long as we can focus on a life event that is actually based in your experience, then we can move from there. And what that looks like is, first we get to know each other and talk through, who you are, what you're about. You need to trust me before, obviously, we're going to go into some sort of difficult part of your life. We're going to talk through who you are. We're going to make sure that you don't have any conditions that are contraindicated. So we don't do EMDR with pregnant people because we don't know that it's damaging, but we don't know that it's safe. So we hold fire and wait until that person has had their baby. Also, if you have any sort of seizure disorder or epilepsy like that, moving your eyes in the way that we might use eye movements could be triggering for that seizure disorder. So there are things like that that we consider to make sure that a client is appropriate for EMDR. The other thing we're looking for that is an early phase of EMDR treatment is not even, many people come to EMDR treatment and think we're going to jump right in and do the processing or the bilateral stimulation. And there are a couple phases that we do before that to make sure that a client has the skills to calm themselves. Essentially, I want to teach a client to be the driver of their body and of their neurophysiological experience. So what happens when we have an activating experience is our body goes on hyperdrive and our sympathetic nervous system takes over and tries to protect us from what seems like it's a dangerous experience. And our brain doesn't know the difference between a real experience, the saber-toothed tiger, and an imagined experience of that saber-toothed tiger. And so the physiology of what happens in our body is the same, no matter if it's real or imagined. So it's important that if we do bring up those memories, even in an imagined state, that you have the skills, or a client has the skills, to be able to calm themselves. So we work on physical regulation skills. We work on coping and calming techniques to make sure that that client has the adaptive skills necessary, that if we open up those difficult memories, we're going to be able to pack them away, calm ourselves down, and move through our day between sessions. I don't want to open up anybody's difficult memories and have them feeling really intensely and then send them out into the world in that vulnerable, intense state. So one of the things that many people report back appreciating about EMDR is just the coping skills and formality of walking through coping skills that we do as a preparatory phase. EMDR essentially works with what we call adaptive information processing. It takes memories that were stored and almost get stuck. It's as if you might know someone, or you yourself might have had an experience. We see it, I'm trying to think of everyday examples. We see it in divorce, where someone might obviously go through a hard time, but then years later still be stuck in that difficult emotion around it. When things aren't moving for you, when things aren't getting better over time, then it might be an indicator that some of your memory processes are processes are stuck or frozen and need some help and stimulation to move through to a more adaptive place. Our body has an amazing ability to heal, the same way that if you cut yourself and your body will naturally heal. Difficult experiences are naturally processed, and our brain is wired to place those in an adaptive place. Typically that happens in REM sleep. It's our brain's time to rest and process everything that happened in the day. If we're having a particularly difficult dream and we wake up in the middle of it, for example, then our brain may not have processed all the way through to completion to put that memory into a place that supports us. EMDR also uses the rapid eye movements, but it's different from dreaming. The clinician makes through that the client stays with the memory and with the processing until we're through to take the trauma processing to completion. The last thing we want is to leave you in what I call the dark tunnel. If we imagine going on a train through a tunnel, and EMDR processing often takes us to these dark places, and for a moment it can feel overwhelming. And so I often tell clients we stop at any point that they want to, but let's get to a break in the tunnel so that at least when we're between sessions or you're between processing, then I want you to take a breath and feel a little bit of reprieve. So part of what I think the skill that I'm trying to teach clients when I'm working with them in trauma work is learning to feel their emotions and not be scared of them. The goal is not to not feel sad or not feel scared or not feel upset if you were wronged or harmed or had a difficult time in any way. The goal is simply to not let those experiences drive you. When we've had challenging life events, if those memories are not placed in a productive place in our mind, then we can often be in a state of reactivity. We know that when someone's had a trauma, that their hippocampus actually can shrink, in which case we may be more animalistic and more reactive to triggering events. I saw a documentary one time about physical pain, and it was studying young children who had chronic physical conditions where they needed invasive treatments. And it was challenging the theory that we should have like a built-up tolerance for, if, for example, if a kid was, had to have needles poked in them often as a child, some doctors and parents and people thought this child should have a tolerance and should be really adept at being poked and prodded. And what they found was quite the opposite, that the human physiology is such that those pain receptors get open and they're more vulnerable. And so we think of it very similarly psychologically. When we've been through big T or little t traumas, it can shrink our hippocampus and it can make us more reactive, if not processed, to the point where we feel like we are more vulnerable to triggering and being reactive. And so we want to shift that for people so that they can move through life and feel like they can respond without reacting to everything that's happening to them. They can have an emotional experience, take a breath, sit with it, calm their body, and then choose how they want to respond, verbally, behaviorally, or not respond, right? And feel like they have a sense of control. Oftentimes when people have unprocessed trauma, they describe feeling out of control and feeling like they have outbursts or meltdowns. And sometimes other people can't even tell that that's going on. This might happen internally for someone. But it's a very distressing experience to feel like you can't regulate your own emotions. So that as a result, some people start to avoid emotional experiences. They might avoid relationships. They might avoid things that feel similar to what they've gone through before. And so we don't want that trauma to be depicting what your life looks like. I want you to be in the driver's seat. I want you to decide what things work for you, don't work for you, from a place of grounded confidence instead of a place of reactive avoidance. So there are some questions people ask about EMDR therapy. One of the ones I often get is, will I be conscious and in control? And the answer to that is absolutely yes. Some people associate it with hypnosis, but it is not hypnosis. You are fully aware, you're fully conscious, there is kind of a sense of your brain taking on a bit of a role that feels a bit unusual, if I'm honest. It's the only time in my life when I've participated in the EMDR, it's the only time in my life that I can recognize feeling my brain work. And I know that's a bizarre way to describe it, but even after the processing had ended, I could almost feel my brain moving things around. It was a bizarre sense, and it wasn't a physical sense, it was just an awareness I had. So one of the things we know happens for people with traumatic experiences is a disconnection from physiological states. We think this is likely because they get easily overwhelmed, and so then we become disconnected with our bodies. And so EMDR, in its base, is an attempt to integrate our memories, integrate our emotions, and integrate that mind-body connection so that we can really feel like we are in a peaceful space in our lives.
Hi, I'm really glad to be with you. My name is Sue Levin, and I am a licensed professional counselor, licensed marriage and family therapist, and I'm the executive director of HGI Counseling. We're also known as the Houston Galveston Institute, and we're a nonprofit organization that does counseling and trains mental health professionals. We were founded in 1978, so we've been doing this work for over 40 years, and I've been with the organization almost that long. I started as a therapist and learned how to both do therapy, supervise clinicians, and became a faculty member and now an administrator. And I'm very excited to be with you and talk about what we do at HGI. Let's see, we have services and offices in both the greater Houston area as well as in Fort Bend County. We started in Galveston as an outgrowth of a team working in the medical center at UTMB. This group started family therapy practices in the South Texas area. One of the first groups in the country to do family therapy. And at UTMB, they were out of the child psychiatry department. Family therapy was a radical idea when they started in the 50s, 1950s, and started working as a team with patients who were struggling with issues that had them hospitalized. And they began understanding problems as occurring in a context. And family therapy was developing all across the country and across the world. And these were the early beginnings of that approach. Inviting in other people who are involved in trying to help children cope with issues and problems, but sometimes also helping in ways that were maintaining the problem rather than resolving it. So family therapy really engaged the family and then started expanding as well because systems, not just the family systems, get involved when a kid is in trouble. That includes schools. It includes other systems like sometimes probation, the legal system, protective services when there's issues around abuse and neglect. And all the helpers, people who are hoping to take care of and assist with problems that show up in kids, sometimes can be in conflict with each other, like parents who are taking different approaches or can't agree on how to parent a child, which creates a situation that can add to or complicate a problem. And then this can also happen among helpers outside the family. So when a school support person, a counselor, a teacher, and a family get at odds with each other, or when a caseworker from protective services or other organizations have different agendas and are not able to work together on the same page, you end up with a chaotic system which makes resolving issues more difficult. HGI has been looking at these kinds of systemic issues for many, many years and developed an approach actually in the 1980s called problem-determined systems, which then evolved to language systems, because what we started looking at was sometimes the problem wasn't really in the inherent inside a person or in their psychic system and the individual system, but it was an issue that came up as people started talking to each other. And so how can we understand what the meanings are and the language is that people are using as they're trying to work out and support and resolve problems? And these things only get worked out and resolved in language, in conversation with each other. So who's talking about the problem? Who's trying to help resolve the problem? And how are they doing it? What are they saying? Who are they talking to? And how can we engage all the people who are relevant to this system in bringing in resources? There are a lot of different programs out there that look and think about these things these days. But early on, as I said, originally back in the 50s and then into the 80s, the people at HGI, our founders, our faculty have been practicing and thinking about these things. And today, our current approach has evolved and is now called collaborative therapy. So collaborative therapy was originally named and labeled as far ago as the 1990s. Harlene Anderson, one of our founders and a continued faculty member, board member, and thought leader at HGI, but also around the world, has written books now about this, and there are many published articles in the literature. We have our own journal called the International Journal of Collaborative and Dialogic Practices, which I think is getting ready to publish its 11th edition of the journal, and it's bilingual in English and Spanish. And we're also part of an organization that's international and provides training in these approaches, and that's a collaborative certificate program called the International Certificate in Collaborative and Dialogical Practices. And there are 16 different centers around the world that are part of this international network. Both in the United States, we have 2 programs at the moment. There are 3 programs in Mexico. There are programs in Brazil, Argentina, Peru, Ecuador. I know I'm going to miss some of them. Colombia. There are programs in Europe, in the Czech Republic, in Norway. There are programs in China that are very popular as well, in China and Taiwan. And so these programs are great opportunities for us as a community to learn from each other, to practice in different ways, and to share ideas, both through conferences that we co-host every 2 years, as well as through our journal. And then with our actual training programs, HGI has been offering a 20-month intensive training in collaborative and dialogical practices through this network, and just completed our 5th cohort. And this is a group of, I believe we had 22 people who participated in every other month seminars, 2 days a month, or 2 days every other month, excuse me, coming together and having workshops, having dialogue, and practicing together. People who are therapists, but also educators, administrators, people who are interested in bringing collaborative and dialogical practices into different organizations, into their own communities. Our focus has been around how do we talk with each other? What kind of language do we use? And we've come to call this dialogical practice, meaning that in dialogue, what we're doing is really trying to explore our conversation with each other rather than monologue. And what I mean by that is we often are talking to hear our own thoughts and to share our own thoughts without inviting the other person's ideas and responses to influence us. So monologues are when we are stuck with an idea that we're trying to convey to somebody else, and it may come across more as giving advice, sharing something that we're trying to convince the other person about. Whereas a dialogue is an opportunity and an invitation to explore things together, to create a conversation where we are learning together, where we're exploring together. And it's not necessarily just two people, but rather it's a process or a philosophy really about how we can explore and engage with each other to create new ideas and new meaning, new solutions if we're talking about issues and problems, and come up with new ways of understanding and approaching things. So many of our conversations and the responsibility of us as facilitators of those conversations or as mental health professionals are to ask questions that are open-ended and that invite our clients to share their ideas and create space for clients, whether that's an individual client, a family, a group, or even an organization that we're consulting with, to talk about their ideas in ways that maybe they haven't had opportunities to do before, to create openings and space for them to think out loud about things that maybe they haven't felt comfortable sharing with other people and that they've been holding in their heads. And sometimes these inner conversations end up becoming problematic. We could think about people even to the extreme of people who may have conversations in their heads with others that become called psychosis, and that these are things that they are not able to share with other people because other people get scared when they hear them. Other people shut down those ideas and those concerns when they hear them from a loved one, when they hear them from a friend, or maybe even when they hear them from a client. Some therapists are trained not to support and make space for those conversations to happen because as a society, we've been taught that these are abnormal and not appropriate conversations. But what happens, and one of the things that we have found and really are exploring, not just ourselves, but there's a big movement, especially in Europe, but also around the world, called open dialogues, back to dialogical practices, where especially people, if you can start working with them at the early onset of what's considered psychosis and create space and support for them to be able to share these ideas, that they can be successful at adapting and and moving out of what can become a real difficult situation if they're not allowed to or given space to express these things. So once you are shut down, and as I said, it's typically by people who are well-meaning but scared and don't know how to handle and engage with people who are having this very scary experience themselves. So once they feel like they can't have these conversations, they go inside and they become conversations that happen internally rather than externally. And the more they are internalized, the stronger they get. The more that they're unable to let these things out, just like all kinds of feelings and experiences that we have that are disturbing, like anxiety or fear or trauma. If we're not able to share these with other people, they can become more and more powerful and more difficult for us to manage. They add to isolation. I'm probably talking to people who have these experiences, right? Or have worked with people with these experiences. So I don't want to belabor the point, but it's really important. And one of the big things that we find most valuable about our work is in creating places for people to talk about things, again, that they may not have shared with others before, or if they've shared them, that they have been discouraged from talking about them or told that they're inappropriate. These can also include feelings about suicide, for example. A lot of people are not given space to talk about feelings when they have them about suicide. So when therapists work with clients who feel suicidal, sometimes the very first thing that they do is ask them to make a contract not to attempt suicide, not to explore this issue. They are, they are brought into a more technical conversation around signing agreements or making agreements which stop the conversation rather than asking clients, tell me how you got to this point, and giving space around helping them air the pain and the suffering, which is very difficult for people sometimes to hear, certainly for family, certainly for friends, and for those people who have had these feelings and not have anybody to talk to about it. Going to a therapist may be the first time they really are hoping to have that conversation and to get some help around it, where the response of, I'm going to need you to sign this agreement or to make an agreement with me that you're not going to attempt suicide, may be a very difficult shift from what I really wanted to talk to you about, which is that I'm feeling really stuck and I'm feeling really lonely and I'm feeling really hopeless and I don't know what to do about it, and I really want to connect with somebody who can talk with me about what will help me in this struggle that I'm having. So again, creating space for these conversations is what our therapists are really good at. And our network of therapists who are trained in this collaborative and dialogical approach. Again, we are offering trainings, as are many organizations around the world. And we also have literature and participate in workshops and trainings, invited to speak at conferences and those sorts of things, where we can offer this way of being to other people. I'm trying to think about how to share what we're doing, though, on a more local level. because I think there may be people in Texas, people in Fort Bend and Harris County who may be interested. And so I think I'll shift and talk a little bit about that, if that's okay. So our work in our offices has been disrupted a little bit, as many have been, by COVID. And so luckily, we have been doing online and remote therapy for many, many years. Before there were regulations, before there was a lot of technology that made it possible, we were working with people over the telephone. We were working with people because access to services is something that's always been important and really one of our missions at HGI. We went out and did home-based therapy for years as we were, as I said, really focused on family systems and how to work with a whole family system, and working with Children's Protective Services where clients couldn't get to us. And, you know, therapists for a long time have operated in our little offices and expected everybody to come on our schedule to our places of work and operate within our comfort level and our boundaries. But that's a really privileged position, and therapists who really want to serve the community have to find other ways to do that. HGI has done a lot of disaster response, and another thing that we did going way back to after, let's see, I guess it was Tropical Storm Allison in Houston, we were working alongside the Red Cross in Red Cross shelters, providing mental health support to people who had just experienced loss because of hurricanes, but also to the Red Cross workers who were hearing terrible, difficult stories, you know, first responders as well. So we've been doing this for a long time, but I'm really wanting to emphasize how important it's been to us to experiment with different ways and different places to work. So one of the innovative things that we were able to do after Hurricane Katrina, in addition to working in a mega shelter and helping run the mental health services at the George R. Brown Convention Center several times, not just after Katrina, but also after Harvey and other disasters, is that we got a mobile mental health unit. We were funded out of an organization called AmeriCares, actually, to purchase a 32-foot recreational vehicle and outfit it to provide services, because so many of the, I'll call them refugees, evacuees, who were moved to Houston after Katrina hit New Orleans, were people who didn't know how to navigate Houston, people who often were using public transportation in New Orleans, and the public transportation system in Houston, where they were housed after Katrina, where they were moved, was not available. You really have to have a car to get around the Houston area. And many of the folks who were sent here were really stuck in apartment complexes with very little resources and very little opportunity to get out and get to what they needed. So our mobile unit would go and visit the different apartment complexes, and our therapists worked on the unit, and the residents began to understand that we were there to help. And we also brought the unit to schools where many of the children who were displaced to Houston got schooling. So that's just another one of the ways that we have adapted and are flexible to meet the needs of the community and provide access. But back to COVID and what's going on now, We've been doing teletherapy, we've been doing remote services as well for many years. And when Texas instituted some guidelines and requirements for mental health providers, I believe it was about 5 years ago, including that people needed to be trained to provide services, we started offering training in teletherapy to Texas mental health providers. So HGI has been doing that for a while, and then when COVID happened, we offered free training for mental health providers. We have lots of resources, and of course our therapists already were trained, and we offered our own therapists supervision and support as we all pivoted to provide services to our own clients. This includes working with schools, and I'll talk a little bit about that as well. We've done work in schools since the beginning of the Institute, which is over 40 years, as I mentioned. So again, not expecting clients to always come to us and to always show up in our offices. We know that having therapists on site in the community is one of the best ways to make therapy accessible, and part of the community services, part of the systems that they're already operating in. So schools is one place where obviously mental health services are really helpful and supportive and can take the burdens off of the schools, off of families who can't always participate or get their children to therapy after hours. But in schools, we can go in and partner with the schools and create a resource and a partnership, and that's something we've done with many different organizations, community youth services, communities in schools. These are national organizations, and then also directly with school districts. So right now we are working in Fort Bend County with the Lamar Consolidated Independent School District and have expanded over the years. Not a lot of years. We've started, I think, 4 years ago with one therapist part-time in a high school in Lamar Consolidated. And right now we have, I think it's 18 therapists working in almost every school in the district through partnerships with the school and funding with local foundations. And this expansion was rapid, and particularly due in the last year to knowing that COVID has added stressors to all the kids, all the families in the district, and that is going to continue as schools are adapting and having to fill needs academically as well as emotionally, socially, and psychologically for kids who've had a lot of trauma and families who've had a lot of trauma and losses in the last year. So we do work, we continue to do work online. We are beginning to look at working back in our offices as the risk levels are going down, people are getting vaccinated, but we expect to continue offering services online because frankly, they are very convenient. People don't have to take off and drive to an office to get services. If they have a private place, they can do it from their office and their job. They can do it from home. They can do it from their car if they don't have a private office or space in their home. And it cuts down time and expense for those people who may have to take, a cut time off from their job to go and participate in therapy. So we found that this can be a very useful way to provide services. It also helps, especially when we are needing to engage multiple family members, couples in therapy. And, we do offer services in the evenings and on Saturdays, which makes things more convenient. But at the same time, having people being able to join from different locations, maybe families where they live in different households because of divorce and separation. We can bring everybody together to help their kids to resolve family issues using technology in a way that makes things a lot easier on everybody. So we do expect to do that going into the future, and as I said, can train other organizations that are wanting to use these technologies in working with their clients and supporting them through and beyond the pandemic. Let's see, what haven't I gotten to that's important to share about our work? Mind-body medicine and wellness workshops. So one thing that we have done as part of our disaster response, but has continued in our work, in all of our clinical work, is that many of us have been trained by the Center for Mind-Body Medicine in doing mind-body skills work and wellness workshops. And what that means is that we've studied how trauma and stress have impacted our nervous systems and our health in ways that we don't always pay attention to and recognize, and how the ways that we think about ourselves, the ways that we manage our stress are really impactful to our health and vice versa. So we can improve our health outcomes, for example, blood pressure, diabetes, our immune system, by taking care of ourselves and practicing some very simple wellness and self-care tools, simple breathing techniques, and doing these on a daily basis for 10 minutes a day, for 20 minutes a day, taking care of how we eat and being mindful of how we make choices, not just about food, for example, but also about how we schedule our time, how we take care of our relationships and take care of ourselves. A simple example is not hurrying through getting dressed every day just to get started with our day, but taking the time to pay attention to the little things, the really taking the time, ask your dentist about how you should really brush your teeth. It can take a little bit longer than what you may rush through to do that, and allowing yourself to take care of that for your health and wellness, allowing yourself the rituals of doing the self-care each day before bed, for example. How many people really have trouble going to sleep or sleeping well because of carrying around stress and worry? And mindfulness helps us let go and recognize what we can really do something about. And when you're trying to go to sleep, you really can't do anything about something that's due to your work the next day. unless you decide to get up and take care of it, right? So why worry about it if you're trying to go to sleep? We have to find ways, and our wellness workshops teach these things, and we bring them into all of our work when our clients and our colleagues are dealing with some of the same issues. All of us have our own issues that can become problematic as we ignore ourselves. And as helpers, that's often an issue for us. We're so used to taking care of other people and not putting ourselves first. And that can mean that we're not good at taking care of our own stuff and dealing with our own stress. And that can get in the way for us. So first we have to know how to take care of ourselves before we can really take care of other people, or we're going to run out of the energy and the compassion and the care and resources that we have to give other people. So self-care is a critical piece. And again, what's tied into it is health and wellness. So we have to be healthy. We need to take care of ourselves. We need to sleep well. We need to move and eat well and breathe, and yes, all of the things that are important. And we can help our clients, our families, our friends when we know those skills, when we practice those skills ourselves and can share them with others. So that's something we've started doing. Again, we got trained over the years, and there's quite a few people in the Houston area, I think we're at 200 now, who've been trained in this approach, and HGI has quite a few of our staff who've had the training. I've become a faculty member of the Center for Mind-Body Medicine, and I help train other people, but I also facilitate groups and workshops. And HGI has a program now that's called the Whitetail Wellness Program that is for Fort Bend County and organizations in Fort Bend who can get trained for their staff and the organization so that the helpers can continue doing the best work that they can possibly do as they both take care of themselves and take care of their clients. Yes?
Can you let us know how would I pay for this? So do I need to pay if I come and get a counselor through HGI?
Oh, great question. So the question about payment, both for training, for wellness programs and workshops, and for clients who want counseling services, is as simple as let's work it out. So often we have funding that's going to cover a portion of the cost or the full fee. So for counseling, we do have a sliding scale, and it's based on clients' income. And you just come and tell us, or call and tell us, what your income is, what you think you can afford. Because even clients who have decent income often have other financial constraints. And we take that into account. We work with you, and we do have clients who come in on a pro bono basis, meaning they pay nothing, but also low fee. And for those who can afford it, we're happy to accept your regular full fees as well, because that helps us offset those other discounts that we offer. And again, luckily, we're very grateful to have support from foundations and donors that allow us to offer these programs and counseling at no cost and low cost as well. So yeah, just call and ask us. A lot of our information about our programs are available on our website, which is hgicounseling.org, hgicounseling.org, and you can look up information there, but also about how to contact us if you have questions.
Hello, my name is Rick Tremp. I'm the president of Living Works. Living Works is an organization that focuses solely on the issue of suicide. Living Works has been around for 37 years, and we're an organization that teaches our programs and provides services all across the globe. Living Works believes that everybody has a role to play in addressing the issue of suicide, and we have trainings for every one of those roles. We do this with a community development lens where we believe that anybody in our communities has a role to play in preventing suicide. We believe that these roles change where people live, work, and play. We believe that, that it's really important for these roles to be interconnected and to have connections in order to keep people safe from the issue of suicide. We believe in partnerships. We believe in working with other organizations. We believe that Living Works is a key player in that, but we can't do that alone. It's just like the old adage of it takes a child to, or it takes a community to raise a child. Same thing with suicide prevention, is that it takes a community to keep people safe. Living Works is an organization that really believes in evidence-based approaches, and I want to talk about that for a minute. All of our programs are evidence-based, and this is really important because suicide is a very serious subject matter, and you need to have good evidence-based programs and services in order to effectively address the issue. We have over 50 peer-reviewed journal articles and pieces of evidence that support our programs, and we won't release a program unless it is built in evidence. Living Works has been fortunate enough to train over 2 million people globally, and we're very proud of that, but we believe that we haven't done enough. And so our goal as an organization is to actually do that annually. And that's one of our objectives. It's our mission, is to create safe communities. The issue of suicide is a significant public health challenge. It affects every community, it affects every individual. And people know that suicide is a major issue. And in the United States, for example, 47,000 people took their lives by suicide in 2019. We know that there's significant community impact when that happens with every individual. We know that there's particular demographics that are at greater risk. And it's really important as we talk about approaches to this issue that we take a community look at this. And so I like to say it's really a population issue. It's an issue that takes a population of people to all come together and to help keep people safe. I want to talk a little bit about the Living Works programs. The Living Works programs, as I mentioned, are evidence-based programs, and we take a very evidence-based approach to how we deliver and facilitate our programs. One of the key things that we really believe in is standardization, and through standardization you achieve quality, and that quality aspect to Living Works programs is really job one for us. The programs themselves are designed to train specific roles in our community, and so those roles are skills-based. They're not awareness roles. They're really skills-based roles that create community connection. And so in Living Works, when we have our suite of programs together, we can articulate safety nets, and so people become connected with those individual roles. At Living Works, we call that a network of safety. When we surround the individual who's at risk, when we're creating skills within our community, one of the things that's really important is that we keep people safe for now as they reestablish their hope, and that's a journey. And that's a journey for the individual who's at risk. And so our programs such as Living Works Start is an online program. It takes an hour to an hour and a half to complete. It's you can take this program on your iPad, you can take it on your phone, you can take it on your personal computer or your computer at work. It's a program that's been very well accepted. And it's a program that's, once again, evidence-based. That program actually teaches how to identify somebody who might be at risk, and what to do with that individual who's struggling. And so it's a really important skill to be that identifier in our communities, and to know what to do and how to ask that question: are you thinking about killing yourself? Are you thinking about dying by suicide? And that's a really difficult question to ask people, but it helps you overcome almost your own personal beliefs, your own personal stigma about that, and really teaches you the importance of asking that question directly. Safe Talk is another one of our programs that's, once again, evidence-based. It's widely used and widely accepted. The Safe Talk really provides the background for suicide alertness. It really develops a skill of intuitive awareness. So it's a face-to-face training. It takes about 3 to 4 hours to complete this training, but it really gives you the skill on how to be aware of the surroundings around you, how to be aware of individuals that may be at risk, and it really helps people identify people who are having thoughts of suicide. Safe Talk is meant for anyone 15 and older who want to promote the issue of suicide alertness, and also really create a mechanism of safety in our communities. Living Works Assist is a 2-day program, and it is intensive training. But it's a really important skill in our communities. Living Works Faith, I want to talk about faith for a minute. It's a new program that we've put out for faith leaders to really develop a skill on how to address the issue of suicide within perhaps their congregations, how to talk about this issue, and how to overcome some of the issues around suicide within our church community. This program is fairly new. It's only about 4 months old, but it's an amazing program that we're very proud to offer to our faith leaders. This program really challenges some of the thinking and creates an environment for study and for self-reflection and prayer. This is one of our important aspects of our community, where people in crisis will actually come to their faith leader, and we want our faith leaders to be skilled around the issue of suicide, so that they know how to address that issue effectively. The program itself takes about 5 to 6 hours of study time. Longer if you really want to go deep into the studying and the reflection piece of this. And we're very proud to offer it as a resource and an ongoing resource to our faith community. With suicide, the opportunity here for all of us is actually to identify a role for ourselves. Living Works really believes that everybody can play a role in our communities. And those roles can be anything from an identifier to somebody who actually intervenes, and everything in between. I want to talk a little bit about the approach that LivingWorks uses. So I've talked about the programs, I've talked about LivingWorks as an organization, but really what it comes down to is how do we actually do this? And so LivingWorks builds strategy with our customers, with our groups that we work with, whether that be a church organization, whether it be a military, or whether it be a school system, construction organizations, health systems. What we do is we come in and actually we help develop the strategy. This is a really important aspect to what we do, because this could be shaped as a program where it should be easy to implement. It should be an effective approach, and so really important that we establish goals and objectives and really develop an understanding with our client group so that we can come in, tailor our standardized programs to make sure that we're actually meeting the cultural needs of those particular populations of people. We'll never stop suicidal ideation because it is a natural human characteristic, but we believe that we can actually make an impact on stopping suicide loss. And we do that by giving this, not only this training, but also with a view of reestablishing hope for that individual who has lost hope for now. And so it's really important to surround people with a safety net that helps them reestablish hope, helps them go on that journey and have that safety net around them so that when they do fall down below the threshold a little bit, that there's a safety net there to keep them safe and help them along that journey. That's our mission, and that's a really important mission for us. And I hope that I've been able to show you how LivingWorks goes about doing that, and we'd be more than happy to work with any organization to establish a network of safety within any particular organization.